Distribution is the reversible movement of a drug from the bloodstream into the tissues and interstitial fluids of the body. This phase determines the extent of drug delivery to its intended site of action and, equally important, to potential sites of toxicity. The journey of a drug through the body is governed by key concepts including regional blood flow, tissue permeability, tissue binding, and critically, plasma protein binding. We begin with a fundamental pharmacokinetic parameter, the apparent volume of distribution. The apparent volume of distribution, abbreviated VD, is a theoretical volume. It is the proportionality constant that relates the total amount of drug present in the body to the measured concentration of that drug in the plasma. The formula is volume of distribution equals the amount of drug in the body divided by the plasma drug concentration. It is crucial to understand this is not a real physiological volume but a mathematical concept. Interpreting volume of distribution values reveals much about a drug's behavior. A low volume of distribution, approximately 5 to 10 liters, suggests the drug is largely confined to the plasma compartment. An example is warfarin, which is highly bound to plasma proteins. A medium volume of distribution, around 10 to 40 liters, indicates the drug distributes throughout the total body water, both extracellular and intracellular fluid. Aminoglycoside antibiotics, which are hydrophilic, exhibit this. A high volume of distribution, greater than 40 liters, and often far exceeding total body weight, signifies the drug is extensively sequestered in tissues away from the plasma. Lipid-soluble drugs like amitriptyline or digoxin have very high volumes of distribution. The clinical utility of the volume of distribution is profound. First, it is essential for calculating a loading dose. The equation is loading dose equals the target concentration multiplied by the volume of distribution. This calculation is critical for rapidly achieving a therapeutic drug level in acute situations. Second, it helps predict drug behavior. For instance, a drug with a very high volume of distribution is not easily removed from the body by procedures like dialysis. Now, let us explore the concept of plasma protein binding, which creates a dynamic reservoir in the bloodstream. Drugs in circulation are often bound to plasma proteins, primarily to albumin for acidic and neutral drugs, and to alpha-1 acid glycoprotein for basic drugs. The key pharmacological principle is that only the free, unbound fraction of a drug is pharmacologically active. Only the free drug can cross capillary membranes to reach its site of action, and only the free drug is available for metabolism and excretion. The clinical significance of protein binding is multifaceted. Altered binding conditions can change drug dynamics. In hypoalbuminemia, seen in liver disease or nephrotic syndrome, or during acute phase reactions where alpha-1 acid glycoprotein increases, the free fraction of a drug can rise significantly. This can lead to an increased pharmacological effect or even toxicity, despite a measured total drug concentration appearing within the normal therapeutic range. Another consideration is drug displacement interactions, where one drug competes for and displaces another from protein-binding sites, a classic example being sulfonamides displacing warfarin. However, it is crucial to note that this transient increase in free drug concentration is usually quickly corrected by the body's increased elimination of that now unbound drug. Therefore, clinically significant displacement interactions are relatively rare and typically only become problematic when the displaced drug also has a narrow therapeutic window and its clearance is simultaneously impaired. Furthermore, protein binding is saturable. At very high drug doses, the binding sites become fully occupied, leading to a disproportionate and potentially dangerous increase in the concentration of free active drug. Next, we must consider specialized tissue-specific barriers that selectively restrict distribution. The most prominent is the blood-brain barrier. The blood-brain barrier is a highly selective interface formed by tight junctions between capillary endothelial cells in the brain, reinforced by the foot processes of astrocytes. It serves as both a physical and metabolic barrier. For a drug to penetrate the central nervous system effectively, it typically requires high lipid solubility, low molecular weight, and a lack of strong ionization at physiological pH. Additionally, Efflux transporters like P-glycoprotein actively pump many drugs, such as the antidiarrheal loperamide and numerous chemotherapy agents, out of the brain, further limiting their central effects. This has direct clinical implications. Treating conditions like bacterial meningitis or cerebral abscesses requires selecting antimicrobials known to cross the blood-brain barrier, such as third-generation cephalosporins like ceftriaxone or agents like doxycycline. Another critical barrier is the placental barrier. It is not an absolute barrier. Lipid-soluble, non-ionized, low molecular weight drugs cross readily. This is a paramount consideration regarding teratogenicity and fetal effects, informing the avoidance of drugs like angiotensin-converting enzyme inhibitors, warfarin, and certain anticonvulsants during pregnancy. Other sanctuary sites that pose similar distribution challenges include the testes, the prostate, and the vitreous humor of the eye. Several factors can modify a drug's distribution. The drug's own physicochemical properties are primary. Its lipid solubility, often expressed as the log p-value, its molecular size, and its degree of ionization, which depends on the relationship between its pKa and the environmental pH. Physiological and pathological states also play a major role. Neonates have a higher percentage of total body water and lower plasma protein binding capacity. Pregnancy increases total body water and decreases plasma albumin concentration. Obesity alters the volume of distribution differently for lipophilic versus hydrophilic drugs. Disease states like systemic inflammation, uremia, which can alter protein binding, and conditions causing edema or ascites, all significantly impact how a drug distributes. Let us integrate this knowledge with clinical applications through brief cases. Case 1 involves calculating a loading dose. A patient presenting with rapid atrial fibrillation requires rapid digitalization with digoxin, a drug with a very high volume of distribution of approximately 500 liters. A standard maintenance dose would take days to achieve a therapeutic effect. Therefore, a calculated loading dose based on the target concentration and volume of distribution is essential. Case 2 involves treating a central nervous system infection. The choice between penicillin G, which has poor blood-brain barrier penetration, and ceftriaxone, which penetrates well, is dictated by our understanding of distribution principles for bacterial meningitis. Case 3 involves altered protein binding. Monitoring. Phenytoin, a highly protein-bound anticonvulsant in a patient with hypoalbuminemia, requires careful interpretation. The measured total phenytoin level may be misleadingly low, while the free active drug level may be adequate or even toxic. Dose adjustments may need to be based on measured free phenytoin levels. Case 4 involves understanding tissue-specific toxicity. Aminoglycosides, with their medium volume of distribution and hydrophilic nature, accumulate in the renal cortex, explaining their nephrotoxic potential. In contrast, chloroquine, with a very high volume of distribution and affinity for melanin, can accumulate in the retina, leading to characteristic toxicity. In summary, the distribution phase of pharmacokinetics determines where a drug goes in the body. It is governed by the theoretical volume of distribution, the dynamic equilibrium of plasma protein binding, and the selective permeability of specialized tissue barriers like the blood-brain barrier. Understanding these principles is key to predicting drug action, rationally optimizing dosing regimens, especially loading doses, and anticipating or avoiding drug toxicity. The drug, now distributed throughout the body, is poised for the next critical phase of its journey: metabolism. Thank you for watching. Don't forget to like, share, and subscribe. See you in the next one.